Amy Loden Tiffany. I am an internal medicine doctor by background. I own Vitality Medical and Wellness Consulting at Missouri Baptist Hospital and really do quite a bit of learning that I can't stop. And so my husband's told me I'm not allowed to get more certifications, right? So it was lifestyle medicine and then obesity medicine and menopause medicine before that. If they had something for postpartum moms, I'd probably have that. So I just love learning. I love taking care of people in all different phases. But what I'm really passionate about is helping women identify their risks, their hidden risks for diabetes and for heart disease, stroke, and dementia. And so we do a tremendous amount of work in metabolic medicine and in that role, particularly finding outcomes that pregnancies identify, like preeclampsia, or that menopause identifies, such as severe vasomotor hot flashes. And so super excited about how can we change the tide in women's health specifically, but also knowing that moms influence dads and they influence grandparents and all the people at the schools and the kids. And so investing in women is a really valuable investment in our society, and helping them to be better and caring for their families and their communities is what we enjoy doing. So that's me. I'm glad to see everybody here. Excited to be here. This started as a brainchild actually just last summer, and it's been a really fun endeavor to work together with everyone and see it grow. So glad everyone's here.
Thank you. I love that. I agree with all of that, and I share the same sentiment. My name is Dr. Sarah Jensen. I'm board certified in dermatology and also dermatopathology. I was in academia for a number of years after out of residency, and I went out to my own in private practice about 15 years ago in Festus, Missouri, down in Jefferson County, just south of St. Louis. And recently, I've opened a second practice in Chesterfield. I wanted to be closer to home. I also found myself kind of stuck in my career kind of after the pandemic. I felt like I could do dermatology in my sleep, but I really wasn't growing. And I realized the medicine that I seek out as for my family and as a female in menopause and for my kids, I seek out more integrative medicine, kind of out of the box medicine, I guess. But, we go to acupuncture. I sought out like functional medicine cardiologist. And so I realized I look at more preventative, like nutrition and exercise. I think even my trainer and good friend is on this chat. So it's great to see her. There was a Learn Skin. It's an organization that looks at integrative dermatology, and they actually have a certification course. So I did that online and in person a few years ago, graduated, and I've incorporated that into my practice. And I find that patients seek me out because of that. I joined St. Louis Institute for Integrative Medicine, and that's a huge community that's burgeoning. I just feel like people want not just to treat a symptom, they want to know what's going on. And I know doctors kind of cringe at the root cause question, like what's the root cause of what's going on here? And but I do think there's something to that, not just throwing a pill at it, like thinking about obesity, about hormones, about all these things. And so that's where I am. I'm in now a year into the second office. I have a few PAs who work with me. We'll keep it probably at that level. And I've just really enjoyed. I came up into knowing about Dr. Lynn through my own course in perimenopause and menopause. And I hope that other people don't have to experience that in the manner I did and as delayed as I did. And I'd love to talk about that because it really hones in on like why I get on a soapbox. You can tell I'm going on too long. Get on a soapbox about menopause and perimenopausal care because it's so undervalued, under-recognized, under-researched, all those things. So I'm happy to be here. So thrilled.
We are so happy to have you here.
Thank you.
I think a lot of people resonate with what you've said too. Sorry, I can't get my mic turned on fast enough. But I think a lot of doctors cringe to your point because that's not how they're trained. They're taught that these other ideas are poisonous, that they're toxic, that they're harmful because there's not so-called evidence. But evidence is simply how we define it. So glad you're here. Love your story.
Thank you.
So excited to talk more.
Thank you. So I can go further and just kind of go into how I found Dr. Lynn because it really touches on all the things that I see in my patients, and I try to get to them before the age that I found Dr. Lynn and this kind of community of menopausal care. Would that be of interest to anybody?
I think that would be great.
Sure.
Yeah.
I found myself way before the pandemic. I'm 54 now, just had a birthday. And I probably went through menopause, the changes in maybe about 4 years ago. Before that, I was, not getting a cycle because I had my IUD, but I found that sex became just painful. And I mean, it's something people don't talk about it. And I found, I thought to myself, gosh, I'm only nearing 50. Is this what it's going to be like for the next half of my life? And I would just kind of toss that out the window. That's such an important part of my relationship with my spouse. And the kids are now going out of the house. And I'm like, is this what I have to look forward to? And I was really disappointed. I sought out academic medicine doctors at one of the bigger institutions in our community. And they were younger, and that's fine, but they didn't really understand the changes that I was going through in the way that I felt them. The terms at an academic center were like, it's just going to get worse with time. They offered some options, topical estrogen vaginally, and but I tried to explain to him. I said, it's kind of like I have a new leather shoe and I'm trying to stretch it out. That's how I feel for maybe 20 to 30 minutes after sexual activity. I mean, it's not just not enjoyable. It's like painful. And it's just it's a terrible way of being. And so I remember reading actually they self-made this. I'm assuming the clinic had made this sheet about dyspareunia, like painful sex, and there was all these steps you could take. The very last one, which just horrified me and made me realize I was in the wrong place, was if all else fails, just lube it up with topical lidocaine. Just, you don't need to feel it. Just I thought, one is that it's really horrible for a female, but it's also dangerous. We could get tears, pain, bleeding. I mean, and I just realized I needed to go somewhere else. I found Becky Lynn when she was still in academia at St. Mary's. She offered me a plethora of options. There was like this waxy bullet of Intrarosa. There was, again, the estrogen cream. There was the patch, or the Bijuva, the estrogen and progesterone. And after trial and error, she gave me all these options, just said, take them home, try them. And I finally narrowed down on a really nice regimen and have been, working in conjunction with Dr. Lynn with patients, and also, my own care, although I'm really bad about following up, and I will make my appointment after this.
Okay.
We take care of everybody else first.
Okay.
And so I just sought refuge with Dr. Lynn and all the symptoms that go along with menopause, like the pain, the belly bulge, the dry skin, easy bruising, skin tearing, you name it. There was a brain fog, even anxiety, and all these things I actually sought out my primary doctor at the time for. What's the one thing that gets thrown at women? Oh, how about I put you on Wellbutrin? Okay. And I'm like, yeah, but I've been researching this. I've been researching the Women's Health Initiative, and it just doesn't quite make sense. And once I logged on to a Peter Attia of The Drive, his podcast, number 42, I have it on my handout that I give to patients. It really helped me completely understand why we are at this phase, and why and how kind of misguided we've become, and why there's so much misinformation about menopause. There's not enough data. I mean, you guys, I'm preaching to the choir, but there's just not enough studies, and patients go looking in different areas because we as allopathic providers don't offer them the tips and the tools that they need. And so I see them, and I've seen them in going for pellets, and I used to see them at the academic center for hair loss and the acne and the chin hair that would come along with all those pellets. And you just know there's better science-based ways to get to this care, and that's what brought me to Dr. Lynn and this community of menopause specialists.
Thank you.
Yeah. It's like,
and I was just going to say, the whole dyspareunia thing, like, it is so important to have a good sex life, and a disruption in your sex life should never be blown off. Oh, you're just getting old. Oh, it's, whatever. Like, it is so important to a happy, healthy relationship. And the sad thing is, women aren't taught anything about sex, right? Like, we're taught how not to get pregnant, how not to get an STD. Not if I'm not having pleasurable sex, right? Like, so lidocaine, like your point, it's just taking the pain away, but like, hello, what about the woman's pleasure?
Right.
And so, I do feel it's really important to talk about sexual issues. Sex is just part of who we are as human beings. The vagina is just a body part. We don't have to be embarrassed saying the word. So, I'm really glad that we could help and that everything was
Yeah.
taken care of. And yeah, so
Yeah. Well, and speaking of pleasure, it's a good relationship when you can actually text or message. I can't remember how I did it. Your doctor, which would Dr. Lynn, the first time I had an orgasm after all this, going back and forth to the doctor. So I thought, I don't know if it's too much. I don't think it's too much information for Dr. Lynn, but I was so thrilled. I'm like, it's back, and I'm going to work on it even being better. So it was like, it's just life changing. I mean, it's me, my partner, it's our kids, it's our relationship. It's a woman's health, is really needs to be at the forefront because we're taking care of everybody. And if we're not satisfied, no one is. So
yeah.
I'll step off my soapbox because I could go on and on, but I do have a really nice sheet that I hand out to patients explaining where we are, different podcasts, people to listen to, doctors who will give this care. And also, verbally, I tell them where maybe to avoid because you can get down a rabbit's hole. And then I go into the whole genitourinary syndrome of menopause because, God forbid we learn about this in residency or in medical school. I went to school at St. Louis University. I was taught by like a world-renowned gerontologist, Dr. Morley, and we learned about male menopause and ad nauseum, and there's just testosterone that men need, not a peep about female, menopause. And I'm hoping the tides change, and so I try to share that freely, and also with my kids too. Like I've learned not to just talk about, like you said, STDs, obviously as derm, I do, hone in on some things that they need to take care of, but it's about pleasure and about putting themselves first in their relationships and in their sexual health. So, but
and I've appreciated those resources you've put together. You shared those with me before, and it just helps for me because as a psychiatrist, a lot of times they see me more often than they're seeing a lot of other physicians. So I get a lot of questions about these things. And so, they don't realize, they're surprised pleasantly that there are other fields that are thinking about this. So I'm like, no, I know a dermatologist that is like very passionate about this and the resources that she also has. And it's just been really lovely getting to cultivate these relationships over this past year.
Yeah. And I make sure, like, I stay in my lane as far as like, I'm not going to prescribe you, systemic drugs, but if there's someone, vaginal estrogen can be used anywhere from 45 years on up. And, I've learned so much just from this community, the North American Menopause Society, about treating like lichen sclerosis, which is, kind of a scarring down of the vulvar tissue and even perianal tissue. We've always treated that with steroids, topical steroid, which works, but you can't use that forever. And you can thin the skin even more if you're not careful. But I've learned to add like estrogen to that condition, which helps. I get people who have like burning or irritation. It's vulvar tissue. It's kind of that overlap tissue between gynecology and urology and dermatology, and I feel very comfortable offering that to a patient, with all the studies that show that there's no increased risk with breast cancer with the topical estrogen and vaginally and in the vulvar area. So I feel like I'm going to get you on this and get you on the road to someone who actually can help take care of this better. So it's been really helpful. And Becky and I have been talking about estrogen now. For the face, people are using estradiol cream, estrogen cream, and there's a third one. I think estriol.
Yeah.
I think that's the one I've been using just because it's a nice compounding pharmacy, and estriol or estrogen cream has now been used, and it's all the buzz in dermatology about using it for face and neck and any kind of tissue. And it really it's benefited me. I'm on the systemic, so it really helps. But I've also added it both topically, intravaginally with the Intrarosa, and also as the cream. And it's been very helpful. It stimulates, collagen, elastin, reducing wrinkles. I only wish I had this stuff, when I hit 45, 48. And so that's my goal, to get this information out to more people an earlier phase.
So what do you tell people about changes to skin that happen during menopause?
Oh gosh. So
Loaded question.
no, it's okay. I mean, we have so many patients who come in with chronic itch, that came on later in life, and that can come from a variety of reasons, right? We lose our oil glands are not as active. We do have a lot less collagen, less elastin, and we dry out. That can happen just because of age, but also estrogen has a huge role in keeping the oil glands, functioning and producing collagen. And that also can help with like skin tears. We have a lot of, I was suffering with skin tears. I suffered with a bruising on the arms. And I thought, gosh, I'm in my 50s and I'm already getting this, what they call senile purpura, a terrible term, but my bruising, my skin tears have drastically improved. And I bring it up with my patients. And I mean, it's anecdotal, that obviously there's not the studies, but we've got to work with what we have. And I have patients who say the same. Oh, I didn't even notice. You're right. I'm not bruising like I did. I mean, it's a joke around our house. The kids know I bruise easy. There's even a song by it, by Renee Rapp. So they, but I'm no longer. There is the fat development again around the waistline, and it's not so much that I treat that. That's more appropriate for like Dr. Lynn or primary doctors. But I acknowledge it and I say there's a reason for that. Hair thinning, hair loss. There's even
Let's
changes
talk
to
about that.
Yeah, we can talk about hair. That was
Tell us
my
what you do for that, because my patient
Huge.
population, everyone's struggling with hair thinning.
Right. And that was actually my focus in academia. It's actually where they wanted me to go in academics. And I thought, well, I really want to study I really want to treat the whole person, not just their hair loss. So that's actually the nidus for me going out in private practice and being who I really want to be as a doctor. But hair loss is still, I do get a lot of referrals from the people who know that, that was my main focus in both derm path, looking at it under the microscope and also treating it. There's different types of hair loss. The most common type I see is the androgenetic or female pattern, male pattern hair thinning. And what I've always told patients, men expect to lose their hair and are happy when they don't. Women never, again, just like sex and, health, they're not told that they could get hair thinning, and they likely will get some degree of hair thinning. And I don't discount women who come in with this full volume of hair, hair I've never seen in my life, and say, oh, but you had such thick hair. Whatever a woman was used to is what she wants right back. And I'm not going to say that it's going to get back to the hair of our teens or 20s, but we can definitely improve it. So I look to see if they have any kind of vitamin D deficiency. We do check their thyroid. I look to see iron levels, the ferritin, the stored iron. And and I don't know if it's controversial with allopathic medicine, but integrative medicine, we also look at the values. And, we don't want you to just be at the value for vitamin D is in the 30s to we're over the 100 range, right? We don't want you to just be at 35. We want you to be like in the 60 or over range. Same with your stored iron. We want you to be 60 or over for most ranges of labs. So I take 5,000 units of vitamin D a day. I make sure I get plenty of iron because it is hard to absorb those, iron supplements. So we check those, make sure their thyroid's functioning well. We make sure there's no stressors that have happened in the past 3 to 6 months prior to that. So maybe COVID or pregnancy. We often think of pregnancy hair loss, but after delivering, even a car accident, being under general anesthesia, all those inhaled pain relievers and muscle relaxants. So anything that kind of traumatized them will show up as a shed of hair. So that's what I find most. Patients will come in not knowing that they've had female pattern hair loss for many years, but they have this sudden shed and all of a sudden it shows. There's this wide part, there's the hair's receding back on the temples. So we'll address it with the lab work, addressing any of the stressors that are going on. And then there's a plethora of drugs we can consider. You can start with topical minoxidil, which is Rogaine. We do it at high concentrations, compounded at a pharmacy like Old Mom and Pop, and they put it together, compounded and added dutasteride, finasteride, these classic drugs that men have used, finasterides being Propecia, which men use for prostate enlargement. We add those topically to it, and then we add some medicines that will help it penetrate the scalp. So I used that for a number of years myself and it helped, but I found I got better results when, I switched to oral minoxidil. Oral minoxidil is a blood pressure medicine. We use it at very low doses, just daily, 1.25 mgs a day. And it can very much help with hair growth. Now, there's always, the side effect for women and men is also hair growth other places. So, of course, along comes the peach fuzz. My little Hispanic heritage mustache came back in, after I'd already lasered it off years ago. But you take the good with the bad. And I figured I'm kind of trying to see the glass half full. If I've got hair growth on my upper lip, I'm also getting in the scalp. And that was true. So I just deal with this cosmetically, and reap the benefit of the other. You can use, so one thing that can happen with minoxidil, you can get retained fluid. So I found, I'd go out to dinner, have a little excess salt in the meal, going out to a restaurant. Next thing, my hands and feet are kind of swollen. So I'll add sometimes a sprinkle of spironolactone, which again that's a diuretic. It keeps you from holding on to fluid. It works again on hair growth because of the anti-androgen properties. It can work on the hair growth that we have here. It works on the hair loss we have here. It can decrease the hair growth in the chin and face area. And also if you're getting any menopausal or, at any time of your life, acne, that's hormonal, it can also work on that. So a little bit of each is my solution for myself, and I find that works for a lot of patients as well. So I've gone off the topicals. I'm just sticking with the two oral pills for now. There's also red light therapy. I don't really have a great answer for that. They're not cheap. They're these helmets that, and you've seen them all on, everyone's selling a red light, mask. And I think the value in that, one, you have to know what you're getting. And all the different the wavelengths of the red light. I think that Dr. Twyman is probably the best resource for that, for the red light therapy and the data behind that. I just think there's no harm to it. I just don't know how much benefit they're going to get for that cost for regrowth. And the last thing I do, if I've maximized everything, we consider what PRP, like platelet-rich plasma, which we draw from the patient, we spin it down, we re-inject it into the scalp. That can be very effective. It doesn't work for everybody and it's not cheap. So I try to maximize all the medical therapies first. And then if they're very motivated, we'll go to those therapies. And lastly, I do have a relative, an in-law who owns a gloss salon. We'll sometimes send patients to her for the weaves that they do if they really have exhausted everything, and there's other places like that in town, but I just find that they tend to have a very a good outcome.
So there are two questions.
Yeah.
My question. So my question is, do you always start with minoxidil plus spironolactone, or would you ever start minoxidil and then add spironolactone if needed? Only because it can lower testosterone, which is why it works, but then it can affect libido.
Right.
And the second question is, what are your thoughts on Nutrafol, which I'm actually very curious, your thoughts on Nutrafol as well.
Yeah. So I don't start both at the same time. I always start minoxidil. Typically that's my go-to, and I do it at a low dose. I'll tell people to take the pill either every other day or cut it in half, take it. And then we can increase it to the full 2.5 milligrams a day if we need to, make 3 or 4 months down the road if we're not seeing enough regrowth. I don't like to start more than one thing at a time, because I tell people if we're getting results, we're stuck with both, and if you can do the minimal amount. And so I feel like, and also if you have a side effect, which one was it? So I don't really start a lot of spironolactone right off the bat. It's usually I'm in a little minoxidil. So, and then the other question was, what was the other question? It was actually Nutrafol. Yeah, that's kind of like my red light. I just recently started carrying Nutrafol, and then these articles about liver toxicity sprung up with the Nutrafol patients. I think it's expensive. I think if I had my preference, I would stick with minoxidil or maybe spironolactone, but minoxidil, I probably want to do that plus a topical. I just find things that are so expensive for patients to keep up with. And there are other options that are dermatologist derived supplements, and I've actually been looking into those instead. They're a lot cheaper. I just I have a problem with the pricing. It's just a lot to expect a patient to keep up with. I don't, and I used to say there's no harm and it's just a supplement, but there were really cases of liver toxicity. Now, I haven't seen all that kind of fall through of that, but it does make me pause because they do have that proprietary ingredients that you don't really know what it is. And so I do follow like Jen Gunter, the OB-GYN, and I am cautious about supplements. We carry supplements in our office. I really am a big fan. I like the collagen supplement from Nutrafol. But I really like orthomolecular supplements, and I like Designs for Life. Those are two that I think have really good backing behind it. They will take something off the shelf if there's any kind of impurities in it, and they just hold up over the years, and I've really liked them.
Yeah. So the one thing I'll say about Nutrafol, and I'm so skeptical of supplements because they're unregulated, completely unregulated. But we do carry it here.
Mm-hmm.
And two things about it, because we do a lot of weight loss. People always, their hair falls out because weight loss is a stressor. And I also feel like a lot of people who utilize GLP-1s, we try and get them to eat healthy. We really, really, really try and get them to eat healthy if they're going to use a GLP-1. But I feel like there are some people who they use the GLP to just not eat. And they're really missing out on vitamins. And I've had a couple patients with massive weight loss who start Nutrafol, and it really works.
That's good.
That's like, when you look at all comers, I've definitely seen that. When it comes to data, and I have heard about the liver stuff, but supplements are the #1 cause of liver failure. That's not good at all. And they're unregulated.
Right.
But if you listen to Lauren Stryker's an OBGYN, she has a great podcast, totally evidence-based, and she'll go through all the evidence. And she has one on hair, and she talks about Nutrafol. And I want to say, don't quote me on this, but there was a study in menopausal women, I think, where people on Nutrafol grew 7 more hairs per square centimeter on their head.
That's really great. Yeah.
Yeah. But she, in her thing, so when I heard that, I'm like, wow, that's a lot. But in her evaluation of the evidence, she's like, that's not that much.
Yeah.
So it's kind of how you look at it.
Yeah.
But yeah, it is a tough one because you have to be so careful with supplements.
Right. And I some people do come in on Nutrafol, and we did carry just a smattering of it, but I haven't pushed it. I'm actively looking at these other dermatology. They come up, and I not as kind of sexy of a brand as Nutrafol, not as well marketed, obviously, but much smaller. But I kind of like those like kind of mom and pop organizations. We carry like much smaller brands like Abbey Rose for moisturizer, and I just California Baby, which is kind of taken off. But I like those more just companies that seem to have more integrity, and I haven't, at least my gut feeling of them. And so I'm still investigating. I'm trying to see what I can incorporate at a better price. I just think you have to think about the whole consumer, but I'm glad that you're seeing those results. The studies that I knew for Nutrafol were organized by the company itself too. So there may be others out there, and I'd have to look at that, but there's that bias. So yeah.
Interesting.
So I have a couple of questions jump in here, and I love Designs for Health as well. That's what we use in our practice. Integrative medicine is super interesting, right? Because it's so downplayed by mainstream medicine. And yet there's so much that if we look, there's evidence for, right? No one's going to do the study that says, does gravity work? So we have to use logic. So
right.
I think there's a lot there. But what I was curious about, going back to your talking about minoxidil versus the just lost it, spironolactone. I don't use a lot of minoxidil, and maybe it's because in residency, we got burned out on blood pressure meds. I tend to actually do more finasteride and spironolactone, and I'm just curious, in your world, is there a reason not to? Like, if you had to say, what would be your reason not to do that and use minoxidil still instead? Does that make sense?
Yeah, I think definitely. I used a lot more finasteride in residency and early on, but I can use at least, I can use the minoxidil before they hit menopause. We would only use finasteride in postmenopausal women. And the general consensus and kind of what I found in my practice was they just didn't get better like men did. For some reason, men respond to finasteride in a different way than women, and it just didn't pan out. And I don't think I was just losing those patients to follow up. I would write it and then I would not see those patients again. Or if I did see them, they're just not requesting refills. We'd start at like 2.5 to 5 mg per day of finasteride. And so I just kind of, and ironically, what brought minoxidil back was this New York Times article that kind of dug it out of the grave, saying like, this is a drug that dermatologists use. And I'm like, we haven't been using this. And so it really exploded. And it was just a few years ago. It was kind of ridiculous. And so I, of all things, to have a, newspaper bring it back, but it really did. So it's so widely used now. But yeah, I just didn't get people saying this is working, I need it. But I do get that I do get the refill request with minoxidil. So,
That's
that's
fascinating.
my little study. Yeah.
I think what we ran into so much is people wouldn't monitor their blood pressure. And we weren't getting people passing out. They weren't getting that low blood pressure, but they weren't monitoring it. They weren't getting their labs checked.
Right.
And so I think at least when I was in residency, I think we kind of shifted away from minoxidil. So I was just curious what your thoughts were on that. So thank you.
Yeah, I don't see it as commonly used for blood pressure. So, and if people are obviously on a blood pressure medicine, I'm deferring to their primary. I'm telling them, I'm going to write this down for you. I don't want you to take it till you talk to them, all that. So, but it has really generated a lot of success. And so, as my mustache will tell you when it comes back.
Yeah,
Awesome.
I would agree. I take minoxidil myself and it totally works. My hair is so thin and fine and it's added a little bit of texture to it. It's thicker, but I do get peach fuzz now. Little peach
for sure.
fuzz, little chin hair, but I don't care. I just go get my dermaplane facial and it feels so good to get exfoliated and I'm totally good with that.
Yeah. And I'm not a big drug taker. I don't take a lot of pharmaceuticals. I don't take a lot of supplements, but there's a few things. Those are the few things that I tell my patients, because they'll say, oh, do I have to be on this for the rest of my, I think it's just like brushing your teeth. It's just like your blood pressure. You got to keep up with it. And I tell them every year there's something else that hits my vanity counter that I'm now using this to try to work on my neck or, so I think it's just part of, keeping up,
I think something I find overwhelming and that a lot of my patients do is just skincare in general and all the different things, especially if you look at like one product on social media, then all of a sudden your feed becomes like, and I even feel very confused on what would be something that's going to be good for my skin, that's not going to be harmful. Because I am not a big regimen person. I want things that are like simple. And if it's worth it to spend the money on it, then I'll do it. But also if they're like over the counter stuff. So just in general, as our skin changes in our 40s and 50s, if you don't have like problematic skin, if you don't have like acne or things like that, but you just want to keep like some sort of like smooth, youthful appearance, what do you recommend?
Yeah, that's a great question because people want to know that. If I'm overwhelmed when I go to the departments or like even Walgreens, looking at I just stand there and look to see what everyone has to, face when they try to. So I'm in the same vein. I like to keep things simple. I'm not, just moderation and easy things are kind of my keywords. And so I try to get everyone obviously, we want everybody on a sunblock. I tell them face and forearms on a daily basis, just so that you can get the mail or you can go for a run and you're not thinking about those things. Again, that's why I do preface saying, if you're protecting so much, you got to look at your vitamin D levels because those can drop with all the sun protection we recommend. And I tell people, sun is like chocolate. You don't have to avoid it totally. Little bits throughout the day is fine, but a full day of it is not something you want to do. So I like to see someone on a retinoid, a tretinoin. The over-the-counter version is retinol. The prescription is tretinoin or retinoid. They can start with a retinol if they want over the counter, like a ROC, the ROC products, the Neutrogena Rapid Wrinkle Repair. A lot of these products have retinol in it, and those can be a little bit easier to tolerate. But if you really want results, you're probably going to have to graduate to tretinoin, and that is available prescription. It's FDA approved for acne. So if you've got a little acne here and there, we can try to write it and get it covered. and then you've got the benefit of the cosmetic use for it. So the tretinoin will work on really fine, heathery lines, not kind of our smile lines or, you know, lines of movement, but more those kind of crepey lines under the eyes. It works on color, so pigment, when we start to get those tan spots or mottled pigment on the skin. And then it also works to build collagen. So I tell patients they take a little pea size, 1 pea on the entire face, rub it right up under the eye, not the upper eyelid because it'll be too drying, but the entire face gets the tretinoin. And you got to gradually build up a tolerance. If you go home and start using it daily for the next 2 weeks, you'll just be a flaky mess because it makes skin cells less sticky to each other. It helps exfoliate. So it's kind of like Dr. Lynn said with the dermaplaning, it's turning those skin cells over more readily. So and then the last thing I think about, sometimes I'll throw in a vitamin C serum. That's like one extra step. And I think probably the tretinoin and sunblock have more data behind them. C is coming along, but that's an antioxidant. If you're going to use that, it would be morning, you know, just a little drop, a few drops. Vitamin C serums and vitamin C in general is a topical formula is very unstable. So you really want a good product. Like we have Obagi products in the office. Sometimes I'll compound a tretinoin with a vitamin C. We use a company called Skin Medicinals. They're kind of all over the US and they do a lot of compounding. So they'll do the estriol cream for us. They'll do a nice tretinoin that's got a little C, a little hyaluronic acid, something to make it a little more easier to tolerate because you don't want to have that white fine skill, you know, when you're using it. So in my own regimen is that C, I'm sorry, the C and the tretinoin plus a little estriol cream and then a sunblock on top. And that's all I do. I do everything in the morning because I'm a morning person. If you were to do it perfectly, you would use your tretinoin at night because it does get inactivated by UV light. So, you know, those are the things. And as far as soap and moisture, the simpler, the better. I don't like a lot of chemicals and I'm dry because I'm in menopause, you know, so as much as the hormones are helping me, I do currently like Femring for my estrogen. I do a progesterone and I do a little Testim cream. And then I throw in a little Interosa. I'm like I tell my husband, I'm like a cupcake at night, like I'm slathering these things on. I'm like, so I'm like, you got to make it worthwhile because this is a process. I mean, this is not easy, but it matters to me. So those things have helped. And what else for skincare? Those are the main things I think. You know, all the other things you can add on, you know, like I guess if you're having problems with like pigment, we do chemical peels for fine crepey lines. We've just started adding a phenol peel, which is like really high grade medical. You cannot do those for the full face without cardiac monitoring. So we do small areas like under the eye, over the eye, and perioral. And that's for those fine heathery lines that you want to get to. I started doing that again, just with like the education, trying to keep up with new things like learning. I went to a peel course and learned about this blepharo peel. So instead of like going and getting an eyelid tuck, I visited a colleague of mine this time last year in California, and we do this. And now I'm doing this in clinic. It's a phenol peel around the eyelids. So it tightens the skin, you get rid of that outer layer of skin and it tightens, but you can actually make little snips in the upper eyelid instead of that crescent moon that like an oculoplastics would take. And you know, that you have that line scar that heals eventually. You take little snips and do the phenol peel and all that skin kind of contracts together and you can get rid of that excess eyelid tissue. And it's simple, easy. It's like a 10-day recovery. It's really impressive. You know, and you don't have to have these huge equipment or be in a surgical center. We do it right in the office. So that's been a lot of fun. And we also paint the little brown spots that we get from driving with the phenol. So you can do little areas of it. So those are where we're going to. Yeah, yeah.
And I have to come see you.
Yeah, and thank you. And in conjunction with estrogen use, so I found never had rosacea before, never had the flushing and blushing my patients can, you know, discussed. But I would be at the airport or at a restaurant, especially after being in the sun all day or having a glass of wine. Suddenly my cheeks were just like a clown. And I realized there is probably some effect of a little like flushing with my estrogen use. So I've since done a little V-beam or a PDL laser to get rid of some of the you know, not necessary vessels in the skin. I do it maybe once or maybe once a year or every 2 years. It just causes a little swelling, a little bruising, and I'm back to work, you know, well, I work with a mask on, no one knows, but you know, back to myself in about a week. And that's been very helpful. I think some doctors use beta blockers for it, or you can even do a little bromonidine, which is an eye drop that you use. You put a tiny drop of the bromonidine into your cream, and it constricts your blood vessels. So that's kind of an immediate treatment. I've thought about carrying that with me when I travel and this happens. It's not often, but it's really annoying when it happens, and uncomfortable. You actually get a prickly heat sensation. But the bromonidine will contract your blood vessels, and over the next 8 hours, they'll get back to where they would have been, and hopefully that flushing is over. So there's tools to try to help, because I don't know, Becky, if you've had that issue, but sometimes people get this little red nose or red cheeks, you know, when they've been in the sun or had, unlike they did before the estrogen. I don't know if you all see that.
I don't really see that, but I'm definitely intrigued by the, you know, because I have a hooded eye that I don't like, but it's not bad enough that I need blepharoplasty. So you know, that's a big surgery, and it's not.
Right.
Come talk to you in your office and go through the risks and the benefits, and you know.
Yeah, I'd be happy to. I'd be happy to.
Interesting.
Yeah.
So it looks like somebody wrote, does order matter when applying these products?
Well, my sunblock is the last thing I put on. It's kind of more occlusive, because I like physical blockers. I like zinc oxide or titanium dioxide. I like physical blockers because they work right when you put them on, as opposed to the chemical sunblocks, which I never learned that you have to put chemical sunblocks on maybe a half an hour before you go outside. I mean, I don't even know if they say that on the bottle. I haven't looked, but I don't use a lot of chemical blocks. And they tend to be more inert. They don't really irritate people. So I know, Dr. Lynn, you're a runner. You know, I can wear the Elta if I go out running and sweat and it's not stinging. So that's what the Elta product is, a mineral-based sunblock. So by default, I put my C on first if it's a serum. So if it's a liquid, I kind of put that on first. Any creams go on next, and then my sunblock. And again, I do everything in the morning just because I'm a morning person, and I know by the end of the day I'm beat and I'm not going to do the right thing. But if you, in a perfect world, you'd be doing your C in the morning and a little sunblock, maybe, and then doing your tretinoin in the evening and a little moisturizer, you know, to help with that tretinoin. I'm a big fan of ointment-based moisturizers, especially in menopause, but even as my teens use them. I can't keep these balms on my counter. My son is, lubing up. My daughters use them. I love Abbey Rose products just because they have a coconut oil based moisturizer, and that oil, whether it's Vaseline, Aquaphor, or even just cold pressed coconut oil from the store, you can use, but that really penetrates the skin, because your skin is very lipophilic. It loves oil. So better than creams, because creams do have a lot more ingredients in them typically than an ointment. But that's been my go-to, that especially this winter with this kind of weather, is the Abbey Rose moisturizer. So I hope that answered the question about the layering.
And then one thing, what about trends to avoid? What are things you see like on the internet that are really not a good idea, but maybe, going viral?
There's a lot of things out there. So I don't follow TikTok, but I always know when something's on, going viral there. There was like beef tallow, what's the snail serum, all these things. And I think they're just these fads that come up. I'm also careful with masks, like the everyone loves to do them at their sleepovers and with, the teens and up, but those masks, they notoriously break me out. They cause irritation. Anything that stays moist in an environment, like even makeup pad removers, like the Neutrogena wipes, or the wipes people use in the restroom, for hygiene. Those have one of the highest risks of allergic contact dermatitis, because if you think about living in the Midwest and you have a little moist towelette, if it didn't have a lot of preservatives, those things would mold so quickly, but they don't, right? Because they have so many preservatives in them. So I try to keep patients away from those as well. Those are the main. There's so much misinformation out there on TikTok in these formats. It's tough, but if I was better, I'd probably tune into them. But they overwhelm me. Those scrolling through them.
So one of the things I run into in my practice, because we do a lot with cardiovascular disease and trying to reverse it or improve people's VO2 max scores and whatnot. So inevitably, people will start exercising more. They'll start sweating more. And then before they know it, they have back knee or the chest acne and all the stuff. And I can tell them as much as I want that this is not surprising, but I don't always have great answers. I'm like, you can try different and you can try keeping your skin clean, but I feel like that's such a crappy answer. So can you help me here? Like, what can I tell my patients?
Yeah, back knee is a specific, it is hard. It's hard for me too. I mean, it's not just in your clinic. It's a tough one. So it depends on their age. If they're trying to family plan, one really beautiful thing about menopause is the ability to give a woman or a man, for that matter, low dose long-term Accutane. I absolutely love it. It's I don't love to give high doses of Accutane to adult women or men for that matter because of the hair thinning that can result and all the side effects. Plus, in a year or two, I'm going to be back at the same place where we were before. Like it doesn't last; it's not lifelong. You know, all those hormonal changes can cause acne, and they're not going away. So I actually myself, not an acne, sufferer, take a 40 milligram of isotretinoin Accutane once a week. And that's because there's some data that it can improve collagen, reduce wrinkles, improve elasticity in your skin. So I do that just myself. And I tend to be really desert dry. Like I don't really need need it for any kind of acne reasons, but I've used that. And so if anybody does have a little bit of acne, it's like homeopathic doses of Accutane, which people love. They don't want to be on high doses of anything. So maybe twice a week, Mondays and Thursdays, they'll take one pill of the isotretinoin with a fish oil so you can absorb it well. There's really no need for excess labs because you're taking almost just like vitamin A. We even have for those people who hear Accutane and think anxiety, depression, suicidal thoughts, again, there's lots of studies that disprove that. So, and those doses that we're talking about, I don't worry about it at all. But so I'll do the low dose Accutane, and then sometimes I'll do a sulfur wash. That's always nice, but except for some people don't love the smell of sulfur, and it can be expensive. You have to kind of find these niche pharmacies that will fill it for like $30 or $40. If you send it to Walgreens or CVS, it's like $400 for a bottle of a sulfur wash, which is like, I mean, probably one of the cheapest things you should be able to source. Benzoyl peroxides, I stayed away from just because they bleach. And if you have any residue on, then their clothing, their sheets are, stained or bleached out. And so premenopausal though, I'm not a fan of the long-term low-dose Accutane. It's just too much of a risk to both the patient, to my license, it's not really the way you're supposed to be dosing it in general, but it's the way we learned in residency before the iPledge and all these regulations came into play. I'm not a fan of antibiotics. I will use them if I have to, but there's no real endpoint there, right? And so if I have to, I'll try to do low dose, like 40 milligrams of doxycycline, maybe 50 milligrams, but I'm always putting them on a probiotic. So we carry the orthomolecular probiotic too. But again, I just don't love something that it's going to be short term, and when I get them off of it, it's not going to work. And there are foams of tretinoin. There's a Fabuor foam. I haven't used it in a while, and it may be out of, it may have gone generic and not able to get covered, but there was a foam of tretinoin that you could use. But that's a lot, chest and back. I just don't find that's really easy. And it's ironic that the healthier you get, the more you work out, you get acne. Like of all things, I thought that would totally improve. But it's all these teenagers, working out, the college football player, the dancer. And I'm like, where is this coming from? Or the adult who's getting back into shape,
Yeah. And it's so frustrating because you've made this intentional change in your health, right?
Right.
And it's like, I have this dinner I want to go to, and I have this beautiful zit on my chest. It's awesome. I can't wear that shirt.
Yeah.
So.
I do like the spironolactone. I'm glad Dr. Lynn educated me about reducing the testosterone. That makes sense. So that's good for me to keep in the back of my mind. And then we carry, is it Designs for Health? It's Designs for Health, not Designs for Life. I always get that mixed up. But they have a supplement called Acunotral, and it's it's a vitamin A, biotin, zinc, and there's a little D in there. And I do like that, although they say to dose it really high, like 6 pills a day. And I'm like, well, I don't think that's probably sustainable, because you're really kind of giving them a really like supplement form of Accutane, and you don't want to keep that going that long. So I'll dose it smaller, like 2 or 3 times a week, just take a few and see. And that's appeals probably more to those who are just like pharmaceutical kind of shy.
Yeah. No, I love that. Thank you. That's super helpful.
Of course, yeah.
I'm sure I should have bought stock in Different a decade ago, because that's the only thing I know to tell people on that. So
yeah,
thank you.
It's a good option though. It's not too drying. You know, it has gone over, and it has gone over the counter, the Different 0.1. So that makes
still
it
like
easy
this
too.
itty bitty bottle, right?
Oh, yeah.
Super annoying,
for
but
sure. Yeah.
it does work. I just didn't know if there was something better, different alternative. So you've given me some ideas. Thank you.
I like the Acunotrol for those patients, because it give them a little bit of nutrition back. You know, I don't like to get nutrition through supplements either. I do believe it should come through our food, but you know, there's data showing that we don't get the nutrients in our food like we used to. So there is, and I know I was out all summer one year with my young kids when you know, years ago at Innsbruck, lake time, you know, as good as I could to protect, but it was tan. And my D was bottomed out at the end of the summer. I thought, well, if I'm bottomed out here, I can only imagine at the end of the winter. And you know, anecdotally, I just feel like when I supplement with D, I just don't find myself getting as sick as I have when I'm low on D. You know, I do think that immune function is important, and it helps me at least.
There are a couple questions in the chat. One says, how about NAD, which I'm not familiar with NAD, but maybe you are, NAD. And the other is thoughts on hypochlorous acid.
Hypochlorous acid. Is that just a cleanser, I think? I have read about the NAD, and I'm going to profess my ignorance. I have not read enough about it to really have a proficient like answer. I'm happy to look things up and like get back to the group, but hypochlorous acid I have not used myself. So and the NAD, I'm still learning about that. So I hear wonderful things about it. I see it on like the Peter Attia, and who's that other? There's another one who's almost better known. Some neuroscientist at some big academic center. But his podcast. But I haven't had that deep dive into that yet.
Well, any last minute comments? Because we're nearing the end of the hour. So anything else anybody wants to add?
The only other,
okay,
sorry. I'll give it right to you, Shauna. Sarah, maybe you can put in here something about glutathione after you answer Shauna's question.
Glutathione. So I think glutathione, and correct me if I'm wrong, I often will offer people N-acetylcysteine, which I think then links to glutathione. And I have used that. My daughter's a big believer. My oldest daughter, who I think Shauna it's the Shauna I'm thinking about, has trained in boxing. We've used that for her gut health, and I've used N-acetylcysteine. Again, I keep it in my office with orthomolecular, because it helps a lot with OCD behaviors. So people who come in picking, it's so much nicer to tell them to use that than to go on some, you know, they always get upset if you try to refer them back to psych. It's not in my mind, you know, these things are coming out. But I'm actually really good at the picking disorders, because I tell them there's true issues like with infestations in the skin, and then there's also just the nerve related and the desire to pick at things, and we're going to address this because you've already addressed this with 3 other doctors who have given you all this you know, anti-scabies medicine, or you know, and so the N-acetylcysteine has been great for kids with ADHD who want to pick, adults with ADHD, anybody who's just prurigo nodules, like people who just itch more, who have more who scratch more, who have more itch just inherently in their skin. And I found that to be very helpful. I also love low-dose naltrexone, like 1 to 2 mgs per kg, 1 to 2 mgs a day. You can take it once or twice a day, and that really helps with the itch when you really don't have a cause for it. You've looked at everything else. And I've used that both in men and women, especially in the elderly age. They just seem to have this chronic itch. And I hate to put them on antihistamines for the risk of fall and then maybe the increased risk of dementia later in life. So I've loved low-dose naltrexone, and I get that at Goldsmith Pharmacy. They actually compound the pills together and do it at a pretty reasonable cost. There's like very little risk, you know, they get some vivid dreams. I mean, I'm fine with that. And those get better with time as well.
All right, Shauna.
Yeah, hi, I'm here because I don't like to abuse my friendship all the time with Dr. Jensen. So admittedly, I'm probably one of the younger ones in the group, and so I don't have personal experience with so much of this, but obviously it's starting in my low 40s just to see different changes. And while I have used retinol A and I paused for a little bit for laser treatment, is there harms to doing stuff early, or what should I be doing more preventative? Like, it's kind of depressing. I mean, I know when you're in it, it's hard, but it's also depressing trying like seeing it come on. So like if I can have some kind of preventative stuff or started to get it early on, because I'm in the business of fitness, so I already get people that are down the rabbit hole. So I don't want to be in that, so to speak, with menopause. So I'm trying to do my research early as I'm trying to also do it for my business, but also for myself with my skincare and like the hair stuff and all that. So I know my question got mixed up in there, but like, is there preventative stuff that is not harmful that I can be doing now to kind of like, hey, stop, I'm not ready yet. So
yeah, I think this, it's like, I mean, this obvious answers are like sun protection, and I do think tretinoin can be very helpful. And if people are not into tretinoin or they can't tolerate it, we use the Epion's line called lytic treatment. Lytic is kind of like, it's a more botanical line of product anyways, designed by a dermatologist. And that satisfies some of my patients in menopause or who just can't tolerate the tretinoin or retinol. The C can be helpful, vitamin C serums. Those three things I think are like, so sunblock, tretinoin, and vitamin C would be it. People talk about like preventative Botox. I think like, unless you're seeing a line at rest or Dysport or all these different brands, unless you're seeing a line at rest, I'm not like going to inject people just to keep them from moving. And I'm a very like, if people know you've had stuff done, it's kind of like defeats the purpose. Like if we do filler, if we do toxin, anything, it should look like you look, but enhanced in a way that makes you happy. The things that bother you, it shouldn't, we've all seen them with the lips and just looking so artificial, the lashes that we see, everything's just so, just so overdone that I tend to attract a crowd of women and even men that are kind of in middle age, 40s to 60s. Even I've done filler in like 85-year-old women. I don't get those 20 to 30-year-olds that are getting it done at a salon and all that. So it's a real natural aesthetic. But I would say those three things: topical, doing what you do, the nutrition, the exercise. I just think, all those preventative measures can be helpful. And I don't know if that's like anything new that you haven't heard of, but I think it's
well, the only thing missing really would be the vitamin C, and I was curious about that and how to have that. I also just a follow up on the retinol, because I think I have a SkinCeuticals one. My tolerance is pretty low. Like if I do it more often than like 4 or 5 days, like I feel like that burning or the reaction.
Yeah, a lot of people do. And some people will put moisturizer on before their retinol or tretinoin. Some people, we used to do short contact therapy, which kind of sounds like a bear, but you put it on and then 20 minutes later actually rinse it off, wash it off, and put moisturizer on. And there were studies that showed that it could be as effective with just short contact. It's kind of a pain. So I try to just if people are doing it every other day, that's fine with me. Like 3 times a week would be great. If they're just doing it once a week, I feel like probably not the best. And maybe that's the person to just do the once a week of Accutane. If you're not going to have a child, you're not family planning, once a week of Accutane could be great. That's what I do. Take it with a fish oil and I'm kind of done with it. There's also this, I don't know, this new, it's not so new. They're doing studies with rapamycin, which is a pill that people have, I think there's like dog studies to try to lengthen life of dogs. And of course, my brother and I looked into it. We tried it. I don't know if it helps me in any way. They said it might help with like joint pain and all these things. The joint pain that comes over with menopause is a whole nother subject. You've got to get like a rheumatologist in here and orthopedist to talk about that, because nobody talks about the joint pain associated with menopause. But rapamycin is an interesting thing, and I'd like to see more data with that pill. It's supposed to kind of be the longevity drug, along with a lot of things that people are talking about with lengthening your life.
So we have to wrap it up.
Okay.
This was fun. We do this once a month. Typically, it's the first Wednesday at 1 o'clock, but we'll post it on all of our social media. Sorry. Thank you so much, Dr. Jensen, for coming. It was so fascinating. I learned so
Thanks.
much, and we were so glad to have you.
Thank you. Thank you. This was great. And you feel better too. We've got
Yeah,
flu
sorry,
running
I'm
around
getting
the-
over this
Yeah.
cough, but
It's not easy.
But
Hey,
yeah,
it's a pleasure.
I will send this recording to all the physicians. I post mine on the Avora Women's Health YouTube. So if anybody missed anything or wants to share with their friends, and I'm sure you guys will post wherever you post as well. And thank you all for coming.
Thank
Good to
you.
see
Thanks for
everyone.
the great questions.
Thanks.
Yeah.
Bye.
Take care.